Thank you very much for joining us to talk today about screening and diagnosis of fetal growth restriction, FGR. There's a lot that we need to pay attention during prenatal care, and one of that is to actually identify this growth restricted fetus. It is not uncommon. 1 in 10 pregnancies will be complicated by fetal growth restriction. And we know that FGR definitely is linked to an increased risk of adverse perinatal outcomes. And it can and is included in a leading cause of infant morbidity complications as well as mortality. We also know that when a fetus is stressed in utero, we have the Barker hypothesis that in utero, diseases that are occurring via the mother and in the placental unit and the pregnancy unit itself, that these can precede adult onset disorders such as hypertension, heart disease, as well as diabetes. Well, we know that women with uncomplicated pregnancies experience fetal growth aberration and can have severe neonatal morbidity. And fetal growth aberration is often not well detected. When we do third trimester ultrasound, we could screen for these fetal problems even in uncomplicated pregnancies and guide interventions that actually improve neonatal outcomes. That said, there is definitely a movement, particularly in the United States, that we should only be doing maybe 1 or 2 ultrasounds in all pregnant people. So before we start doing more ultrasound, we really need additional evidence to demonstrate cost effectiveness and some clinical improvement. We know a lot about FGR. We know that our ability to utilize fetal growth curves can distinctly predict small for gestational age neonates, and that predicting that SGA neonate also can correspond to prediction of adverse perinatal outcomes. Really greatly appreciate your taking time out of your day, and I hope you have a better understanding of fetal growth restriction, the screening and diagnosis of this condition. Thank you very much.